Good morning, everyone. Welcome to this morning's webinar. So today's talk is going to be about advanced care planning. I know many of you already understand the basics of ACP, so I won't cover those aspects today. And also, this webinar won't be a sales pitch for ACP, nor a step-by-step how to do a guide. So instead, what I really wanted to do was to share some current and contemporary thoughts and insights and consider why ACP remains relevant after 30 years, even though it might have drifted off your radar more recently. So I believe advanced care planning remains important because there are a few other practices developed in palliative care that have been promoted so widely beyond the specialty. The only other examples that come to my mind are the promotion of opioids for all pain, not just cancer pain in the 1990s, in the livable care pathway in the 2010s. Both proved problematic, as you may remember, and caused some reputational loss for palliative care as a specialty. Now, I'm not suggesting advanced care planning fits into that category at all, but I think we still need to examine it objectively and ask, what has 30 years of research actually revealed? So before we get started, allow me to open with a karakia and my pepeha. It's a hui, whae te mataranga, kia marama, kia whae, takina mahi katoa, tū maia, tū kaha, ara atu, ara mai, tātou ia tātou katoa. Tēnā koutou katoa, he uri aho na tāwhiti, ka haina te whenua, I tau ko te pina, ki ranga I o tautahi, ki mi aho ki toa whenua mi o ori, ki mi o ki te maunga kiki, ki mi o ki te awa hapua, no onihanga o hau, ko Oleg toku ingoa, no reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So my name is Oleg. I am a palliative care doctor working in Hospice West Auckland, and I spend a little bit of my time in Minimal Hospital as well. So let's start the morning off with our very first poll. Quite a simple poll. How many ACPs have you been involved in over the past month? Option 1, none. Option 2, 1. Option 3, 2 to 5, or option 4, more than 5. I'll give you a moment to answer the poll. Right, well, here are the results. And I think it's quite revealing. I'm not surprised. Let's close the poll, sorry. I'm not surprised, and I'm sure you're probably not as well. And I think this really hints at something we all have a sense of, and that's the mismatch. The mismatch between what we want to do and what we know we should be doing on the one hand versus what we actually end up doing in reality. And to be honest, I must admit, I'm no better myself. I've never actually undertaken an entire ACP discussion from start to finish and go on to lodge the form in the electronic health record. And so why is that? And today is my attempt to answer this question for myself, and I hope it'll help you as well. Maybe deepen your understanding, dispel some misconceptions, and clarify your role, if any, in this area of practice. I'll use a couple of cases to illustrate the principles that I discuss. They're real cases, but obviously anonymized. And at the end, there'll be time for your questions, so I encourage you to post them at any stage in the Q&A tab on Zoom. I'll be joined by Trish Fleming. I'll get them to just turn their video on, and Cheryl Calvert. So Trish is our Community Liaison Manager and Clinical Lead for POI at Hospice West Auckland. And Cheryl is our Northern Regional ACP Quality Improvement Advisor, and we're very lucky to have her join us as a panelist. Well, both of them join us as panelists today. Right. Thank you, Tristan. Actually. So today's presentation is actually a follow-on from the webinar I gave several years ago on shared goals of care that I helped implement in Middlemore Hospital, along with Amber Davies, when we were transitioning to e-notes. That session looked at the work being done in a hospital setting, whilst this morning we'll look at the same work from a community perspective. So if you missed out on that one and want to know the other half of the story, then I do encourage you to review it. It's freely streamable on YouTube, I believe. So that was the model provided by Amber and I still think it's a fair representation of my current understanding. If you look at how patients are admitted and discharged, then you can see ACP in shared goals of care are processes that capture patient decisions in each of these environments. On admission, or at least within 24 hours, every patient should have the opportunity to discuss and document their shared goals of care. This helps capture their care and reflect their wishes that they hopefully will have a good understanding of the treatments that will be offered if, in case they deteriorate. These conversations are obviously easier when an ACP is already in place and available. After discharge, the hospitalisation experience can go on and shape a person's future healthcare preferences. It also provides an important opportunity to review and update the ACP and make it available in preparation for any future deterioration. So as you can see, ideally, this is a circular process. It means one informs the other, and both are regularly updated to align with the patient's preferences and goals of care as they change and evolve. Neither can easily exist without the other or as a standalone process. So with that said, let's move on to our first case. Allow me to introduce to you Rob, a 48-year-old man with metastatic bowel cancer. He was diagnosed 11 years ago and has been under hospice care now for 3 years. He was a software engineer and lived with his wife and 2 sons aged 20 and 17. They would have been about, 6 and 9 years of age when he was first diagnosed. So Rob had a strong faith in God and said his family was his purpose in life. He said this gave him strength to fight for more time, to spend more time with family, especially to see his sons grow up, which, as you can see, he has actually achieved. He connected with his spiritual side through listening to music and enjoyed playing his guitar. He used cannabis and psilocybin to enhance his spiritual experience. These excerpts are from his ACP. In terms of worries, Rob said he was worried about his loved ones. He didn't want any new health trauma introduced to them, and so some sheltering from his pain was important. Finding him dead at home would not be a good look in his mind. Creating an ACP was important, as he knew he was dying of cancer, and facing the future made him sad and missing out on seeing his boys grow up. When dying, quality of life meant pain was managed so that he could better spend time with family and friends and visitors. He had a wide circle, so it was really important for him to retain his capacity to spend quality time with them all the way to the very end. So what happened? We received a call from his wife one morning. She said he had deteriorated. He was slurring his speech. He had become weak all over. And she felt overwhelmed with these sudden changes. A nurse visited that day, and his wife expressed how challenging it had been seeing him deteriorate over the past week, and the pressure she felt towards protecting their sons. In her mind, she felt Rob was entering his dying phase, and they needed to activate his end-of-life plans. Rob agreed, and together they decided the time had come for him to be admitted into He Whakarongai, our unit in Hospice House. I was the admitting doctor, and I remember having seen him recently at home and thought, although he looked sick and his AKPS was 30%, I must admit, my first impression was that he looked better than expected. So I wondered whether they had made the call too early. Thankfully, I didn't put my foot in the I didn't put my foot in it and voice that opinion. But anyway, we took things one day at a time. And over those days, they made the best use of that time and had lots of family and friends visiting every day, parties, even outings. And looking back now, and I can really appreciate the wisdom of their decision, considering how well it all turned out when he died 11 days later. Rob's ACP was central, I believe, to achieving the death that he and his family desired. So reviewing this, there were clear factors that helped Rob's end-of-life care go according to his ACP. He had a long and predictable illness with a real lived experience, so plenty of time to adapt and adjust to his illness. He and his wife also had quite high health literacy and a sense of personal agency. And this came across clearly over the times that I met them. They were skilled at interfacing with health professionals and navigating the healthcare system. They knew the right questions to ask, never took things at face value. And more important than our words, they valued consistent follow through in our actions. You know, they held us the task and kept us honest. Rob also had clear healthcare preferences that were informed by his value system, which he openly shared with his family. And yet there was no disunity or dynamics within his family. And this was helped by the fact that he was quite psychologically minded, in actual fact, and motivated to talk about quite difficult and confronting topics, not only with his wife, but also, importantly, with his sons as well. And throughout it all, his sense of control, I believe, and ability to direct his own care was preserved right until the very end. So I think Rob's case really demonstrates why ACP is so attractive and captivating to palliative care professionals. When done right, it's very rewarding. It's a very rewarding process both for patients and family, and very satisfying for healthcare professionals. Conceptually, it intuitively makes sense. It honours patient autonomy and self-determination because it's underpinned by patient-centered care and shared decision-making. It reduces low-value health and wastage in healthcare resources. It reduces also decisional conflict and the burden on both family and health professionals in decision-making. Finally, and most importantly, it honours people's preferences and how they wish to die. And as you can imagine, for palliative care, when this first came around, it really seemed like the best thing since sliced bread. So when ACP did first come to New Zealand, it was taken up and promoted extensively. And I still remember the inaugural International ACP conference that I attended in Melbourne in 2010, 16 years ago now. And during that conference, the group of New Zealand delegates, we banded together, we got together and eventually formed the National ACP Cooperative. You may recognise this original website. I managed to find it on the Wayback When machine. And our mission at that stage was to ensure everyone in Aotearoa had access to advanced care planning. Ambitious, but we really felt achievable at the time. The ACP Co-op was involved in quite a number of different initiatives. The one that I mainly participated in was the advanced communication training. I was one of the original facilitators, and Cheryl quickly joined our band following on from that. And I remember traveling all across New Zealand, gosh, delivering the 2.5-day workshop. These were small group based and absolutely intense, especially as we lent heavily on role plays and worked with professional actors. There may be some around, some this morning joining us who went through this training yourselves. And if so, you'll be able to attest to the quality of what we delivered. And I must say, looking back now, what we were doing in New Zealand was world leading at the time. We managed to get about 1,500 people through training over a period of 5 to 6 years before funding dried up. And this was really the golden age for ACP in New Zealand. Fundamentally, what I appreciate now is that what we were actually doing with communication training was empathy training, getting clinicians to become more aware of patients' emotions, as well as their own emotional reactions, in learning how to incorporate this therapeutically for mutual benefit. With funding drying up, the cooperative has been disbanded, and a lot of the initiatives we were involved in have been shelved. This is the website now, as it currently looks. There's still a lot of really good resources in it, so I do recommend you have a look if you're not already familiar with it. In particular, it's worthy to point out that there are now the Māori and Samoan versions of ACP, and these are freely downloadable from the website. You can actually also contact them and get them delivered as brochures to your website. There's also the easy read version through the Understandable website, and I've put their web link in there for your information. There are several e-learning modules which provide great introductions to ACP. And in terms of in-person training opportunities, the intensive training we had been doing has been replaced by the Serious Illness Conversation Guide training, which is a 4-hour training session. Waitemata doesn't offer it currently. I still do them quarterly at Counties Manukau with Cheryl, and I'm not sure how often Te Tai Tokoro or Te Takatumai run them, but their emails are down there, so by all means reach out and contact them if you're wanting to participate in that training. So I just wanted to take a sidestep and mention equity in palliative care for a moment. And this work has recently been released by one of the working groups and describes the new model, the porphyry that occurs between Haukainga and Manahiri. Because I guess the presumption always has been in Western healthcare that patients come to us to seek help. And as such, this creates the power imbalance that we're all very familiar with. The porphyry model flips this presumption on its head and asks health professionals to see themselves as guests invited to other people's lives. And if we accept this role of a guest in a patient's life, then the hope is that it'll help us to ask, as a guest, what gifts do I have to bring to you to enhance the well-being as a gracious host that I've been invited to see? And I think this really puts patient and whānau front and centre, as well as in the driver's seat. And the reason I mention it is because it's actually very similar to much of the communication training we had been doing in the ACP co-op. It's empathy training. And I really like these practical conversational cues they provide. I'm not sure if they had it in mind, but it would be a perfect basis for simulation training. Unfortunately, the working group was only given enough money to do this model at a very high level. Such a shame that there's no intention of investing in any further implementation. So although there's little happening in the ACP space in New Zealand at present, internationally a great deal of work is still being undertaken. The consensus definition of ACP was developed in 2017 by Sudori and underscores the central importance of empathy to achieve the desired outcomes. And I'll read it out loud. Advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure people receive medical care that is consistent with their values, goals, and preferences during serious or chronic illness. So let's move on to the evidence base. And I was surprised to learn at a recent conference that over the past 30 years, more has been published on advanced care planning and palliative care than any other topic except pain. And to put that in perspective, our specialty has devoted more research attention and resources to assessing the value of ACP than almost any other aspect of palliative care. There are now more than 10,000 published articles on ACP and any number of systematic reviews. I haven't been able to keep up with it, so it's been invaluable for me to attend ACP conferences and hear the experts explain things in a way that makes sense. So I'll do my best to give a very basic explanation of the evidence base as I understand it. In the 1990s and early 2000s, despite a lot of research having been published, the fundamental question, how effective is ACP, was difficult to answer, as many of these studies, in actual fact, were very low quality, biased, and had a lot of holes in them. It's only been over the past 10 to 15 years with better research that we're now able to start thinking about and answering the question, how effective is ACP? If not answer, then at least get a sense of the size and shape of that question. But before we attempt an answer to this question, it's important to first ask, well, what effect are you asking about? And this brings us to outcome measures used in ACP studies, because ACP is a longitudinal process rather than a discrete intervention or treatment. There are several outcome measures that exist over the length of the process. Again, Sudori's group has categorized these various outcome measures for us. So let's go through them. Firstly, there are process measures that look at changes in behavior and attitudes in both patients and health professionals. Another type of process measure are action measures, such as number of conversations that are being had and the rate of documentation of these conversations. And then there are the quality of care measures, which include whether the patient's goals are met in satisfaction with the process. And this, of course, refers to whānau and clinician satisfaction, as the patient would be dissident by now. And finally, healthcare outcomes that assess hospitalisation rates, cost benefits, etc. So bearing this framework in mind, how does the evidence stack up? This scope and review by McMahon uses Sudori's outcome measures framework and looked at 69 trials between 2010 and 2020 across 12 countries, with the majority in USA. But before we go on and see what it shows, it's important to point out that only 5 studies were actually in the community setting, with the majority being in an outpatient setting. I think that really hints at how ACPs are done elsewhere in the world, which is completely different to how it's being promoted in New Zealand. It's also worth noting that most interventions were actually quite low level, written material only, a passive video demonstration, or e-learning. Only 9% were the gold standard of clinician training, which was what we had been doing in the ACP cooperative. But anyway, let's have a look at the results. So using Sudori's criteria, 21 out of 29 studies showed positive outcomes in process measures, with improvements reported in both knowledge, self-efficacy, readiness, and attitudes. 48 out of 56 showed positive results in action outcomes. So it seems training really does help to increase the number of conversations in documented plans. This compares to only 23 out of 43 showing positive results in quality of care outcomes. Despite congruence between patient and clinician being achieved, seldom is goal concordant care achieved. Also, it's mixed as to whether satisfaction is experienced with the decision-making process and medical care delivered. It's worth stressing that only one study out of 10 that looked at goal concordant care showed a positive outcome. And finally, only 11 out of 30 studies showed positive healthcare outcomes. So I think that's why there's so much confusion about the effectiveness of ACP, and why some people say there's good evidence for benefit, whilst others hold the opposite view. Yes, ACP training leads to more conversations and greater documentation of patient preferences. The jury's out on satisfaction and health utilisation, but there's little to no evidence that it makes any difference in goal concordant care yet. The caveat is, of course, that most of these studies are from the USA, Most are conducted in an outpatient setting, and many had low-level interventions, written material, videos, or e-learning. But because goal concordant care outcome studies are so central to ACP, and perhaps the only studies that really matter, it's important to spend a little time looking at these studies in a little bit more depth. So I've listed them here. Dettering's study in Australia was the only one with a positive result in 2010. All the subsequent studies have all been negative. And as you can see, they're actually quite high quality randomized controlled trials, and together now comprise a cohort of more than 3,000 strong. Most were in the USA, and 6 had facilitated ACP discussion as their intervention, which pragmatically speaking is the strongest intervention possible. The problem, however, is that all these studies use different ways of measuring goal concordance, and there remains no standardized way of capturing goal concordant care. So these studies can't be directly compared. However, this preliminary evidence is disappointing, I must admit. Let's just say, you'd have an uphill battle securing research funding if you wanted to do a study looking at goal concordant care as an outcome for ACP. So going back to Rob, in using his experience, you can well imagine he would be a good endorsement of all the outcome measures we've discussed so far. I mean, he's literally the ideal poster boy for ACP. Now, the question, the really hard question is, was Rob lucky? Was Rob lucky? Does he represent the minority where ACP does actually work? This is the old HQSC logo, which I like, and I feel is relevant here because it refers to the Swiss cheese model. For ACP to work, a lot needs to be accomplished and aligned in order to generate the sort of positive outcome that Rob experienced. What then is required for an advanced care plan to succeed? Well, firstly, patients must be able to clearly express their values, goals, and preferences, a task that's often more complex than it appears. Secondly, healthcare professionals need the skills, the resources, the motivation to elicit and understand those preferences accurately. Third, family members must be able to make decisions based on substituted judgment, reflecting what the patient would have wanted. However, research shows that families often rely instead on their own preferences and values rather than the patient's. Finally, health systems must be sufficiently mature, well coordinated even, and resourced to support ACP in real life practice. In New Zealand, despite more than 15 years of implementation efforts, I'm not yet convinced that our systems are consistently robust or effective. So with that in mind, and in comparison, let me introduce our second case for this morning, Debbie, 55-year-old Māori woman with metastatic breast cancer, diagnosed 12 years ago under hospice care for 4 years. She worked as the cultural advisor for a mental health unit and lived with her husband and had extensive whānau supports, which she enjoyed. She was raised Mormon and had recently reconnected with her faith. Māoritanga was a very important part of her identity and manifested in all that she did. Unfortunately, Debbie was chronically burdened with a high symptom load and poor functional capacity, and this led to a lot of tensions between her and her whānau. These are excerpts from Debbie's ACP. She wanted to be respected and her mana appreciated within her whānau, and improving communication was a big part of that. She was aware of the araha in her whānau and wanted to be cared for in her whare. She didn't want to return to hospital and preferred to remain at home with her whānau. They meant everything to her. Her strong faith into Aotearoa was her po, and this gave her strength and determination to live every day with gratitude and humility. She had a good awareness and acceptance of her oranga and was grateful for every day she got to spend with her whānau, for the love and care they showed. So knowing these clearly expressed wishes, how did things go? Well, during a home visit one day, the nurse found Debbie was in a shocking state. She had deteriorated suddenly with a pneumonia, Her family felt she was now dying and said it was beyond them to keep looking after her at home, so asked for end-of-life care in hospice. The nurse spent quite a lot of time doing her assessment, appraising the situation, supporting whānau, holding discussions. And during that time, Debbie recovered enough to say a single word, hospital. And I guess though there was a lot of uncertainty in terms of what Debbie meant, as she was confused and drowsy, the decision was made to call an ambulance and she was hospitalized. Surprisingly, Debbie didn't die and recovered sufficiently to be discharged, but unfortunately not back home, but to a private hospital where she died some months later. So just a quick reminder that central to achieving a positive ACP outcome is ensuring the care received aligns to patients' values, goals, and preferences. And so keeping that in mind, let's open up the second poll. In your opinion, does this represent a successful outcome for Debbie's ACP? Yes or no? Just a simple question. Just whenever you're ready to show the results, Grace. Oh, I know, that's I'm pleased about that. It's half and half. That's good. So to be certain, we're all clear about what Debbie's case highlights. ACP is not a goal of care discussion that's occurring in real time. It doesn't replace it, and it doesn't represent a treatment plan for a person who retains decisional capacity. There's a fundamental difference between ACP, which talks about future hypotheticals, versus goals of care discussions occurring at the point in time when the actual decision needs to be made. And therein lies the difficulty of embedding goals of care discussions into ACP documents. Firstly, as you know by now, there are no validated goals of care outcome measures, despite it being the important purpose for having an ACP, if not the sole reason for doing it. Also, as you know, many people adapt to disability that they would previously have deemed intolerable. Sometimes the preferences expressed in ACPs are unrealistic and never challenged or updated. And where people lose the capacity and the ability to express their real-time goals, then we know how much surrogates and health professionals struggle to find the best way forward. Surrogates find it difficult to piece together what their loved ones would have wanted, disentangle their own preferences from the decision at hand, challenge physicians who recommend different treatments, and the list goes on. I'm thinking now, the porphyry model would work quite well in this sort of situation. Decisional instability is the reality, so much so that in actual fact is probably the norm. And let's look at some of the reasons why this might be the case. And I want to touch upon 4 potential processes that occur during an ACP conversation that means they can never replace goals of care conversations. Will to live, hot-cold empathy gap, projection bias, and end of history illusion. So firstly, will to live. This was first hinted in the study by Kochanov 25 years ago. He mapped out people's moment-to-moment will to live and found it correlated closely with symptom scores. And the example he gave here in this graph that I've shown here is an 82-year-old woman with colorectal cancer. Her will to live changed over the year and tracked with her level of pain that she experienced. And as you can see, towards the end of her life, in the final few weeks of her life, her will to live fluctuated wildly. Some days she had a great will to live, other days was very little. And this suggests context really matters. Now, goals of care are in actual fact not set in stone. In fact, the closer a person draws to the end of their life, paradoxically, the more they may want to live. A more recent and emphatic demonstration of will to live came from Malhotra, who published this study in 2000, I forget exactly when. Well, there we go, 2021, of 200 patients with end-stage heart failure. They were followed up for 2 years. Every 4 months, they were asked about the end-of-life preferences, whether they preferred aggressive or non-aggressive approach. And as you can see at baseline, they were fairly evenly split. At 4 months, though, roughly half of each group had changed their mind. And this chopping and changing, this flip-flopping kept on happening every 4 months, irrespective of how close that person came to the end of their lives. And you can appreciate this truly was a palliative population, given the rapid attrition seen over those 2 years. So let's now look at hot-cold empathy gap. I was surprised when I first became aware of this, but thinking about it, it makes complete sense. What we think we'll do when we're in a calm state may be very different to what we actually end up doing when we're in an aroused state. And this is referred to as the hot-cold empathy gap, and also applies to the relationship between patients and clinicians, one hot and one cold, and why a lot of the communication training is focused on reducing that gap. That's why I refer to it as empathy training. ACPs are generally made, as you can imagine, in a cold state, whilst goals of care are made in a hot state. So you can see how these processes help make sense now of Debbie's ACP and how different her goals of care decision ended up being from her ACP. Malhotra also talks about projection bias and gives us a simple way to understand it. So imagine you're on the way home after work and there's nothing to cook for dinner. So you have to stop over at the local supermarket. You missed out on lunch, and rushing through the aisles, you just grab whatever happens to come across your path. I imagine, but what sort of things typically do you think will end up in your shopping trolley? And so this is referred to as projection bias. We make decisions to satisfy our present needs in favor of our future needs. There is a mismatch between how we're feeling now versus how we may feel in the future. We all want to eat healthy, but in reality, we often don't even live up to our own expectations. And this is the same with ACP. Reading through Debbie's ACP, I wonder how idealized it might have been. Did her statements actually reflect her reality? And finally, end of history illusion. So this refers to the fact that people often believe that their personal growth and change have all been experienced in their past, and that their current personality, values, and preferences are fully fledged and realized and settled and will remain unchanged into the future. This is far from the truth, as your future self is no more than a stranger to yourself. Debbie spent her final months in residential care. She and her family, in actual fact, adjusted and made the most of it. If you had have presented her with that possibility during an ACP conversation, I wonder how she might have reacted. I wouldn't be surprised if she gave an emphatic no and shut the conversation down. And so what Malhotra suggests, and I absolutely agree with this, is to make a small tweak in terminology which may fundamentally change our understanding and approach. She suggests changing the term from advanced care planning to advanced care preferences. We're not necessarily supporting people to make plans, but we're encouraging them to express their preferences. I'm not aware of any strong evidence to support this observation, but my experience is that many people are reluctant to commit to fixed goals of care. They're often willing to discuss a range of possibilities, but prefer to keep the options open rather than document definitive decisions. Our current approach to advanced care planning, in which a completed booklet is uploaded into the medical record, may contribute to this reluctance. Some people worry that a documented plan could limit their future treatment options or influence clinicians to withhold interventions they may later want and desire. So a better gold standard of how successful an ACP is may not be goals of care outcomes, but how prepared people are to make goals of care decisions in their moment of need. Looked at this way, every ACP in my mind is a success, as every ACP must help in some way to prepare people for tough decisions they'll need to make in the future. It's better than no preparation at all. And this may better reflect the true work we're trying to achieve. So if I could turn back time, I'd be in favour of dropping the term planning altogether. Although advanced care preferences sounds a little bit clunky, I don't know, advanced care preferences. We'd have to tweak that one a little bit. Let me think about that one. Now we've looked at the evidence for advanced care planning and also some of the problems in decision making from a patient perspective. Let's focus our remaining time on the barriers to health care professionals. So to get us started, our third poll. What is the single greatest barrier you experience in having an ACP discussion? Is it time? Is it training and knowledge, psychological distress, prognostic uncertainty, or lack of support? I'll just give you a moment to answer that. All right, we'll just see what that shows, Grace. Well, there we go. And I'm not surprised. Just close that. And that's been my experience. And I've always felt that's been the biggest factor, time. And look, I've only ever worked in palliative care when it comes to advanced care planning. But I can say I often spend about 45 minutes with talking with patients. And I think that's typical for a lot of people working in this field. It's probably the minimum that I require to gain rapport and complete a values-based assessment. It can't be rushed, you need to go at the patient's pace. And these conversations take a natural amount of time to manifest and gain traction. Unfortunately, time resource is the least available these days, and there's no way of getting around that fact. I don't know how to square that circle. But one of the ways devised to get around time pressures has been to view ACP as a standardized process that can be undertaken once, completed and filed away, one size fits all. This assumption is still prevalent today and perhaps still held by the majority. But in reality, hopefully you can see the opposite is true. ACP is a complex process that occurs over a person's life course. It involves many people and can change significantly over time. So knowing that, is ACP a good fit with palliative care? You'll all be familiar with our current model of palliative care. ACP can be seen as an umbrella that equally sits at either the curative or the palliative end. However, as you can imagine, ACP of a well person is very different to that of a person with a life-limiting illness. You will also now appreciate that goals of care conversations are something different to ACP conversations. So where do they belong? I believe they belong right about here. They sit right about there at the interface between active care and palliative care that provide the true shape of this gradient for each person. So if you're wanting to achieve this model in real life, if you're wanting to manifest this, then you can see the only way of doing so is by having these conversations. Firstly, ACP discussions when people are in the cold empathetic state, and then real life goals and real-time goals of care discussions when people are faced with the actual decision. This is now referred to as the ACP umbrella, published by McMahon a few years ago. And I highly recommend this article that this model comes from if you're wanting to get a more in-depth reading of it. Like McMahon's umbrella model, I wanted to mention another model presented by Amy Chow at an ACP conference a couple of years ago. She first suggested that we need to be aware of the stage of change in a person's mind that they may be in, from pre-contemplation through to contemplation, preparation, action, and review. And this is important as the intervention needs to be tailored and take into account the stage of change. It will be difficult to have a conversation if a person is not aware of the need, let alone prepared. An illness discussion is best undertaken and most fruitful when the preparatory steps have been completed and the person is actually wanting to engage and take action. At the same time, it's also important to factor in the person's stage of illness, whether they're in good health, have chronic illness, or indeed life-limiting illness. Again, the sorts of resources available to each of these groups of people is different. So for people who are well, it's about health promotion, increasing the awareness of that stage of life, public health promotion, social media campaigns, that sort of stuff. For people with chronic illness, the interventions might well need to be different. It may need to be more proactive, targeted screening programs, more tailored discussions. And with people with terminal illness, they may need the most comprehensive approach and benefit from facilitated conversations and specialist team reviews. So if you map out this in a grid way, then the actual task in each grid looks a little bit different. The resources available, the people involved, and the processes and places. ACP is like this jigsaw puzzle, and many conversations are needed to be pieced together before the final image emerges. Just like how it takes a village to raise a child, it also takes a whole community of clinicians to support ACP. And this is now looking familiar, and it's something that we've already touched upon. So I think what Amy Chow is reminding us is to be aware that ACP is about patients and not about the healthcare system. We love ACPs as it allows us to categorize people and reduce the friction they experience interfacing with healthcare services. But do appreciate patients themselves may not view ACP as important or troublesome as we do. And this study shows that health professional priorities do not necessarily mirror patients one for one. It's interesting that they show that ACP is rated by health professionals as very important and very troublesome. In actual fact, it's the opposite for the patient cohort. So I've come to the end of what I have to say this morning. What parting advice do I have? Well, I'm not going to say you must do more ACPs, but if we do strip it back to its fundamental purpose and what the focus of the ACP cooperative was, then we can recognise it's about sprinkling a little bit of empathy into the work we do. The problem is, I know I'm speaking to the converted. The mere fact that you've zoomed in this morning tells me that you already believe this work is important. Difficulty has always been in reaching those others who are otherwise disinclined. So the first thing I actually do want to do is thank you for the work that you're doing already. And if you feel you're doing enough, then that's perfectly fine with me. If on the other hand, you feel like you want to do a little bit more, then I suggest just starting small and making one or two tweaks in how you talk with patients. You need to be opportunistic and prepared to have these conversations. You can't wait for the perfect moment. That'll never come. If you're wanting a signpost, then a good one is, the first time you see a patient after a hospitalization, ask them how it went. What was good about it? What was bad about it? What have they learned, and what would they do differently next time? Would they even want to return to hospital? And then there are the standard ask, tell, ask, and nurse communication tools that will help you draw out the conversation. And if you're feeling really ambitious, then I highly recommend the explore section of the Serious Illness Conversation Guide. It's really helpful to give a very quick but meaningful values-based assessment. So with that, I'd like to open the discussion panel up and invite Trish and Cheryl to turn on their videos and audio. Thank you,
morning,
Cheryl, for joining us.
Thanks, Oleg. Oleg, there was one question that came through that I wondered if you might address to the whole group, and it's around when somebody does not have cognition, are family able to make an ACP, or what would be the situation in that regard? That's popped up a couple of times.
Yeah, absolutely. And there are, resources out there to support that exact process. It's referred to as a supported care plan, and it's something that the family are able to, express and outline, hopefully with consensus amongst them. And so, yeah, that process is very well recognised, supported care plan, as opposed to an advanced care plan. Is that correct, Trish and Cheryl?
Yeah, I think it's worth also noting that the intent of advanced care plans and advanced directives is that they're specifically to be utilised when somebody has lost capacity. So, the advantage to having those conversations early and documenting them early is that you've got that to lean into when somebody does lose capacity, whether that's temporary or permanent capacity. And we can see that timeline as well. and that person's thinking. And as Oleg also said, it's been researched and proven that the carer burden and surrogate decision makers' burden is significantly decreased when people have got the ability to look back at conversations and documentation in that respect. And also collegial and clinician burden is reduced in that aspect as well.
And Cheryl, another thing that I'd picked up that I saw that you answered in the chat, do you think you could just address around the benefits of advanced care planning for the aged residential care sector, Cheryl, from your experience?
So for anybody who doesn't know me, all of my career has been involved in gerontology, older people's health and mental health. Firsthand, I can't speak more highly of the benefits to having these open and honest conversations with people who are resident in our facilities and with their family and whānau. There's such a significant loss of autonomy when people move to residential care. Best will in the world and best service in the world. You're taking somebody from an independent living scenario to a shared care facility. There is a loss of autonomy. Advanced care planning and the conversations in particular, I think, give voice to that person again so that they feel that they are part of the decision-making process. And actually, they're top of the tree. They are the person who still has the autonomy to make decisions that are relevant to their healthcare and welfare and basically their lifestyle and how they lead a good life right through to the end of their life.
And Cheryl,
sorry, just as a final point, just to say that we should be involving people in those conversations to the best of their abilities at all times.
And I met a lovely, lovely lady in aged residential care, Cheryl, who was quietly working her way through her ACP, discussing it with members of the team around her and with other residents. Her daughter hadn't wanted to have any discussions about, mum's future goals of care. When her daughter came to visit on a Saturday, the lady would take her daughter through where I've got to this week with my ACP and what I'm thinking now. And what she was doing was gently guiding and preparing her daughter. Yeah, it was gorgeous. Another question has come into the chat, and that's about the role of GPs and how they could be doing query a lot in this area. What have either of you got to say about that?
Shall I defer to you, Oleg, on that one?
Yeah, well, absolutely. I'd highly encourage anybody who has any ability or interest, just ask these, non-standard questions and do inquire in terms of people's preferences and wishes. And it doesn't have to be a long conversation, but it is important for these conversations to occur naturally. It helps guide people. It helps coach people. Talking about things, voicing their thoughts is so useful, even if it isn't documented. The most important thing is that you've shown you care and you've shared in their experience. So I think everyone has a role. Any patient-facing clinician has a role in this area. So absolutely, I'd encourage whoever has capacity, to do work in this area.
And can I just add to that hopefully most people's point of contact is their GP. I think we're all involved in highly specialist services, and that's generally the top 20% of people who will have chronic health conditions or palliative conditions. The majority of people, hopefully, don't ever get to utilise our services. So it's absolutely those, as Oleg said, multidisciplinary team touch points in our community settings that are absolutely imperative to having these conversations and supporting people in healthy lifestyles and coaching them in those conversations.
And just as you made that very comment, I see Maxine Starling from Haumaru Housing has added the comment in the general chat that they do try to encourage the residents of their pensioner housing to complete an ACP. So that's the community touch points out there. She's saying it's not always successful, and I guess that's just about us being a wider MDT interagency, isn't it? And supporting that to happen, you know. Housing
And people
is...
sorry.
No, you go. Yep.
And people will be ready at different times to have these conversations. And it might be that you're not the right person, might be somebody else who's the person that they will open up to or ask a question of.
That's
I guess
100%.
it's about documenting and handing it on.
That's right. And I guess, you know, Maxine, back to you and the team at Haumaru there, you've introduced the conversation. You know, you've brought, you know, people in to talk about that. You've provided the resources. You've set the scene. Yeah. I guess, Oleg, from the poll, the thing about lack of time being a major barrier, and ACP is a process, not a one and done. And then the training that scored high behind lack of training or the need for more.
Yeah. When clinicians feel stressed, when they're under the hammer, the last thing that they really want to do is to have to face complexity or situations which require more resources than they're capable or willing to give. And so I think that's in our current healthcare environment seems to be the norm these days. And what training really does is to support the clinician to manage their own workload, manage complexity, be kind to themselves, and also in doing so, be kind to patients. It's a no-brainer. You'd imagine. Unfortunately, the bureaucrats and the funders and planners just don't seem to have that understanding. But they're not patient-facing. They never will be, and so they never. So the work that we do never truly resonates at that level. It's just numbers for them, and that disconnect I feel is widening year by year.
Can
however,
I just add to that, Oleg? I think we do more harm if we don't pick up on somebody's cue or if we shut down a conversation. Right. It generally takes people a bit of thought, consideration and time to be brave enough to introduce some of the concepts that are involved with advanced care planning and to open up those conversations for any number of reasons. Just to reiterate, having clinicians who are confident and competent to embrace and broach that conversation is really important.
Absolutely, yeah.
In a great way, if I see in Waitemata currently, that's our rohe here. There is not options for training available, but leaning into colleagues who have experience and being alongside and having that mentorship when others are having the conversation is a great way to learn, Cheryl, right?
Yeah, and there's lots of really, really good online resources as well. They're short, they're sweet. They all add to your PDRPs or your professional development portfolios. So I encourage you to take a look, dip in and out. And the Advanced Care Planning website is just a plethora of advice and information, both on advanced care planning and shared goals of care and the Serious Illness Conversation Guide.
Excellent.
I see this question in the chat. Oleg, just quickly, if we've got a minute, about goal concordant care from Hamish.
Yes. So look, I think a quick answer to that is, I guess, when advanced care plan was first thought about 30 years ago, I must admit, it came from palliative care. We're not psychologically trained or psychologically, minded in terms of the actual science of discussions and emotions. And so it was a fairly basic framework that was initially developed and promoted. It's only since emerged with subsequent research that in actual fact there is this difference between goals of care conversations versus advanced care planning discussions. One doesn't replace the other. You have to do both. Both are valuable. I hope that answers the question. That's what I really wanted to highlight in the presentation today. But we are out of time, sorry. We'll answer the remaining questions. We'll respond to them via email. I'd like to thank Trish and Cheryl for joining in the panel discussion, and absolutely thank the participants for Zooming in this morning. I hope you did gain something out of it, and it's left you with a few thoughts. So in closing, awa kia, tūriki whakataha, haumie, hoie, taiki. Thank you. Go well. Have a good day.